Good afternoon, Dr. David Polsky. How are you?
I'm great, Dr. Wang. Nice to see you.
Since you and I known each other for a long, long time, and I'm just going to call you Dave. Please call
I
me
I,
Steve.
I prefer that. Exactly, Steve. Okay, great.
So we got another great treat for all the audience out there, and I have the distinct pleasure of welcoming Dr. David Polsky, who is an Alfred Kopp Professor of Dermatological Oncology and also the Professor of Dermatology Pathology at the NYU, New York University School of Medicine. And he also served as a Vice Chair for Research in the Ronald Perlman Department of Dermatology. He has a strong clinical interest of taking care of patients with melanoma, atypical nevi, and the skin cancer. Now, in addition to seeing patients, Dr. Polsky is also a physician scientist where he has his own research lab. We're going to talk about some of the great things that he's doing in his lab. And he's also the founding member for the Society of Melanoma Research and a member of the American Association for Cancer Research. And he's also the chair of the Research Grants Committee for the Skin Cancer Foundations. He had published more than 100 papers, so the accolades goes on and on and on. So, David, thank you so much for joining us on the Beating Melanoma Project. Welcome.
It's my pleasure, Steve. Glad to see that you're updating this with all the great new things that have happened since you started this project years ago.
Yeah, it's amazing what transpired in the last 12, 14 years, basically. So we got a lot to cover. Why don't we start off right there? In your mind, from your perspective, what do you think some of the most remarkable thing that happened in the last decade and when talking about melanomas?
Yeah, so the last decade is really a good time frame because it's now 2023, and I believe the first FDA approvals for some new therapies may have happened around 2013. I remember I was at the annual meeting for the American Society of Clinical Oncology in 2011 when the results of ipilimumab, which was the first immunotherapy, were released, and even though the results were not spectacular, they were the first positive signs of a new therapy for decades in melanoma, that something was working, even if it was just a small increase. So, and that really led the way for the advances in immunotherapy, which have been spectacular. Melanoma has really led the way in all cancers in the development of immunotherapy because it is such an immune responsive tumor in many cases. But really, the really spectacular change in melanoma is that not only as immunotherapy became more effective with new agents and combination treatments that have really cured many people and have improved the 5-year survival tremendously. I like to tell people when I first started, if people with metastatic melanoma, maybe 5% of them were still alive 5 years after the diagnosis. Now, probably 30 to 40%, are still alive after 5 years, which means many people really have been cured. So this has been really spectacular. But it's not only immunotherapy, there's targeted therapy. So around that time, the BRAF mutation was, which is like a stuck gas pedal for cells, right? That's what I always like to refer to. A cell is like a cancer cell, is like a car. It's lost its brakes and it's got a stuck gas pedal, so it's going out of control. So these targeted therapies, these small molecules, they basically unstick the gas pedal, which is the mutated protein. And in this case, it's called BRAF, and that basically shuts down the cells, and many cells die. The BRAF targeted therapy, and then in combination with a second agent, the MEK therapy, anti-MEK therapy, really produced also very dramatic improvements in survival, and really spectacular images of patients who were riddled with metastatic disease, in short order could see those disease disappear. Now, of course, the problem is that cells become resistant to these kinds of therapies, and you have to have the mutation that it gets targeted. So, but the good news is about half of melanoma patients with metastases have that mutation, so they are eligible for the targeted therapy. So when you look at the effects of the two together, you see this huge decrease in death from melanoma. And we actually published a paper that came out in 2020, and unfortunately, it came out the week that the United States shut down due to COVID. But there's this very dramatic drop in we showed by looking at population-based data. So not only these clinical trials produced these results, but it actually got out to the population and was, because of FDA approvals, and was being used. And we see this spectacular drop of about 18% decrease in mortality over just about 3 years, from about 2013 to 2016, I think was our data set. I can't remember, maybe a little bit beyond that, but we mapped it with the FDA approvals of these immunotherapies and these targeted therapies. And so there's less people dying from melanoma now than there were in the 1980s, even though the caseload of melanoma has increased. So that's been really, really spectacular. It's
No,
it's the greatest accomplishment in all of cancer, and there's no other cancer that has seen such an improvement in the treatment of metastatic disease and reduction in deaths like this.
yeah, I mean, I think especially the immunotherapy, its efficacy on metastatic melanoma really paved the way for this modality to treat a whole bunch of other type of cancer.
Right, exactly. It's effective in lung cancer, renal cell, others. Yeah.
Yep, yep. So, I mean, I think great summary, and especially I loved your analogy about the brake and accelerator. It's just great. And so I'm gonna shift gear a little bit, because you spend a lot of time taking care of patients, seeing melanoma patients and high risk patients with lots of atypical moles.
Right.
What's your approach?
Right. Well, I think the important thing is to get people into the right frame of mind. I've had patients who come in, they've had multiple biopsies of benign lesions, atypical nevi, and they're tired of getting cut up, so they said, isn't there a better way to do that? And we use, a combination of photography, whether it be total body photography or what's called, people talk about mole mapping, as well as dermoscopy, which is this high magnification and of individual moles, and we can see under the surface, and we have a much higher diagnostic accuracy. So we end up leaving a lot of what I call funny looking but yet benign moles, on patients, and reassuring them that they don't have to worry because, we have these better tools that we can more accurately diagnose them. But some people come in really anxious. I had one patient who came in and said, my doctor told me I was a ticking time bomb. I was going to get a melanoma at some point, and all these moles were ticking time bombs, and I was like, wow, that's like the worst thing you could possibly tell someone, as because, we know from our practice and that of all of our colleagues that most of these moles really are just indicators that patients have an increased lifetime risk, and that if they do develop a melanoma, it could just come out of normal skin. It's not one of these moles is necessarily going to turn into a melanoma. So there's no need to prophylactically remove these moles. It doesn't really improve people's chances of getting melanoma later. So it's really my approach is really to try and calm people down. And then at the same time, someone who just sort of happens to come in and quite doesn't realize that they're at an increased risk. So I go through their sort of risk profile. I ask them about their family history. I ask if they've done any indoor tanning, if they're very light skinned, and red hair in particular is a high risk, what I call phenotype, to say, probably need to come in a little bit more often, and try to get them to do that, and sometimes try to get them to be more proactive, examine their skin. And I'll say one more thing. I see you're about to ask me a question, but one thing that I've started doing for a long time now, actually, is I give them the card of the practice manager. And I said, if you ever have a spot that you're concerned about and you want to come in, call the practice manager, because she blocks appointments in my schedule. Only she can schedule into. So we always have the ability to see somebody on an urgent basis, and patients are so appreciative of that. And they make use of it, and they don't abuse it. They don't just use it for like a routine visit. So it's really a partnership, with the patient.
I can't agree with you more. I mean, I think part of the reason perhaps is, I introduced you to Dr. Alfred Koff, professor of dermatology. Both of us followed this great man, we
That's right.
spent a lot of time, and he was really sort of pushed through the dermoscopy, total body photography, and all that stuff. And he's the guy who actually came up with the ABCDs of melanomas. And one thing I really loved your philosophy, because I really sort of share the same philosophy, right? And I think one thing you said about the ticking bomb issue, right? And I think I completely agree with you. And a lot of times, a patient get a biopsy, came back as a typical nevi, dysplastic nevi. I really kind of dislike some of the explanation that physicians give to the patient. They call it pre-melanoma, which is because they make patient feel like, this is a this thing is really going to turn into a melanoma. You got to
Right.
remove it. But in reality is that's really perhaps not the case.
Right, exactly. I mean, yeah, a couple of issues here. One is the chances of any atypical mole, right? We can look at the lesion in the patient, and we can say, yeah, if we remove that, chances are the pathologist would call it an atypical mole.
Yeah.
But what's actually the chance of one of those turning into melanoma? It's probably less than 1 in 1,000. I mean, there's this old paper from Henson Sao, which I don't know if it was estimating dysplastic nevi or nevi in general, but it was kind of a back of the envelope calculation saying it's less than 1 in 1,000 chance that a given mole is going to turn into a melanoma. So one of my fellows once said to me, well, gee, if you don't think they're pre-melanoma, why do we follow these patients so carefully? Why do we do all this imaging and stuff like that? I said, it's really not that we think they're going to turn into melanoma. It's we don't want to miss a melanoma that's masquerading as an atypical mole, right? So we look at it, we say, oh, it looks like an atypical mole. Then we put our dermatoscope on. It's like, oh, hang on, this is not what I expected. This looks a little bit more worrisome. It's got more stuff going on there. These are the ones I need to remove. Whereas the other ones I look at, it's like, oh, yeah, no, I like to tell patients, oh, yes, that looks that's so benign looking. I could put it in the textbook in the benign chapter. So,
but you mentioned something else is really interesting to answer your fellow's question. Why do we follow them, right? And a couple of things. One is those are the individuals with lots and lots of atypical nevi, and their risk of developing melanoma is much, much higher. You can have
right.
de novo, a new melanoma arising. That's
exactly.
one reason, right? A second reason is that we sometimes don't really know the biological behavior of some of those moles, right? Because at times that's the reason you follow them is, and you may not be able to see anything at this moment.
Right.
This is a melanoma lesion, but down the road the mole can change. But we're just not good enough at this point to know which one of the hundreds on the person's body would do so.
Right, and of course we don't know. So there is a chance that a melanoma can arise in one of these moles. So we do keep track of them, and the baseline imaging, of course, is really useful. And of course we don't know enough. But the other thing is we don't really know about people's exposure. So we don't really know if you get a sunburn in an area of a mole, is that really going to change a small percentage of them or not? So there's these exposure issues and that we don't know about. So all good reasons why people with lots of moles should be coming in on a routine basis.
And there's something else you said that really really resonate to it. I always tell my patient, this is a partnership, right? And then I tell them, unfortunately, they're going to be friends with me for a long time.
Right.
Because I have to trust them knowing that they will come back, right?
Yes.
I will, because if they are not compliant, they sort of just leave and they don't do the follow-up.
That's
and then our methodology of sort of following patients, just don't haphazardly biopsy every single one of those lesions, is not going to work, right? And
exactly.
And I do the same. That is that I always tell them if they see anything worrisome, they just call us. We will try to get them in. So again, great.
Yeah.
So obviously you are very busy, and you have a lab, everything else, and you sort of split your time, and you're oversubscribed because this is you're really good in what you do. And how do you accommodate some of the patient that's far away? And I know that you've done some work on telemedicine and some of the program like MoSafe, maybe, and you also published some studies recently. And why don't we talk a little bit about that?
Sure. So, well, I guess the first thing with patients who are far away and patients with telemedicine. So right now, the licensing requirements for telemedicine are you're supposed to have a license in the state where the patient is seen, where the images are taken. So technically not supposed to be treating a patient, if they're not in the state where you are, or I suppose where they live. I don't really stay closely, up on these things, but so if people live far away, they fly in, but basically people, so I'm in New York, and New Jersey's right across the river, and MolSafe is this telemedicine service, which we'll talk about. And they have a lot of offices in New Jersey, of course, because you were in New Jersey. So, so I have a license in New Jersey, so I can read the images that are collected by MolSafe in New Jersey, in addition to the ones in New York. So,
but before we get into some of the technical part, maybe because can someone just take a picture with their iPhone or something like that? And what do you prefer? What are the limitations? Yeah, and
Yeah.
because I mean, I think there's a lot of limitations, right?
Yeah. Right. Right. So,
And the
right.
reason why I
Right.
asked this
Yeah.
question is that maybe we can also, teach the folks out there like what to look for, how do they perceive when they take the pictures, how
Right.
they send the picture to us for
Right. Right.
examination.
Right. So a typical interaction that I have, and this is for established patients. I'm not going to do this for a new patient. But if I have an established patient and they get concerned about a spot, they send me an image, right? That happens all the time. And then the next message back to them is, sorry, your picture's out of focus. Hold your
Yeah.
camera 18 inches away. Don't use the zoom and just send it to us that way, and have good lighting. So that's kind of just the basics, that you have to be a certain distance, and people have said 18 inches is a good distance away, and then we can zoom it if we need to, but that way at least it'll be in focus and you can kind of see enough of the surrounding skin. So that would be a message to the listeners, in terms of taking good quality pictures.
And then
uh,
what kind of
yeah,
lighting? I mean, we went
yeah,
during the COVID time, people sent us a whole bunch of different pictures, and then we
right.
saw a lot more of their kitchens and living
Yes, exactly,
rooms.
especially with the video visits, right?
Yes, exactly,
Right,
exactly.
right,
But like,
right.
what lighting do you recommend?
Um, I think that first of all, I don't do them by video. They need to snap a picture and
Yeah,
send a picture,
yeah.
and pretty good chance the cameras these days will correct the lighting as best as possible. But it certainly shouldn't be dark, shouldn't be in a shadow. But I would say just uh, uh, just kind of nothing. I don't think anything special. I think people just make sure it's well lit, but it doesn't matter if it's from an angle, the top, the bottom, the side. That's I don't know how to even
Do you have
get
any
people to do that.
preference between natural lighting versus like artificial fluorescent lighting? Or
No,
no?
no,
Okay.
no. Yeah, yeah. Um, so so that's basically people like sending me a picture through the electronic medical record. So and what happens sometimes is I can't tell. I was like, well, you're gonna need to come in because I just can't tell what that is with enough confidence. Or it's like, oh, that's clearly harmless. Don't worry, just keep your routine follow-up. You don't have to come in special for it. So that's usually the extent of that kind of an interaction. Um, uh, and um, and then MolSafe is a whole nother thing, because that's really total body telemedicine, if you will. So people go to a center, and they're examined by a specially trained nurse, and that's really critical because the nurse really you know gets the training that they need to understand what to look for on the skin. They use the ABCDE criteria, but at a lower threshold. So I think their size is 3 millimeters instead of 6 millimeters, right? Because they want to capture anything that's a little bit atypical and pass it on to the dermatologist who's reading the images. And it's not just me from AllSafe. They have other people reading in other states as well.
And I
And then
think the other
yeah,
important thing is, to contrast the difference, right? And someone just sent you a clinical picture from the iPhone,
yeah,
whereas, the most safe and they capturing not only the full body as
right.
well the clinical photo of individual lesions, but most importantly, the
Yeah, the
dermoscopy.
dermoscopy, right. So after they do these total body, then they have lesions that meet these criteria. I call them low threshold criteria, and they have a camera that has a special rod that keeps it at a fixed distance from the skin. So every single clinical picture is uniform in terms of the lighting and the distance and the focus. So you get a high quality clinical image, and then of course the dermoscopy image, which we talked about, provides us with so much more information. And then all gets sent to us, who are diagnosing, and we can basically look at all the lesions that they take the pictures of, and discern, make a recommendation if anything needs to be biopsied or followed up in 3 months, or sometimes we can't tell, and then we say you got to go see your doctor for an in-person visit because there's some technical reasons, that we can't really make a firm diagnosis. And then MolSafe basically sends the report to the patient and the referring doctor. It's a really good way to provide care at a distance. Some patients come in, the plastic surgeon wants to remove these 3 moles, and, they're purely benign lesions, no doubt about it. So it's nice to be able to say, well, it's benign. You don't have to have it off if you don't want to. And that's been very satisfying because patients can be far away, and yet I'm providing care.
Yeah, I mean, I think you really need someone who take those excellent pictures. And I
Yeah,
know that you recently published a study looking at, in clinic, like real life visit versus the store forward type of visit. What did you guys find?
If you're talking about the MulSafe study that we compared, is that the study you mean, where we compared what we found in MulSafe to
The clinical exam.
the clinical exam, right? Yes, you told me you were going to ask me about this, so I have it up. It was about 300 lesions that we recommended for biopsy, and it was about 240 patients. But the bottom line was that we biopsy. So I was the person who it was a review of my recommendations, and for uniformity, and I diagnosed melanomas at an early stage, so they were early stage. The median tumor thickness was 0.22 out of something like 23 melanomas that we found in these patients, whereas the national average is about like 0.5. And we didn't over biopsy. The number of benign things we recommended for removal was not substantially higher than what you would see in a dermatology practice. I think the overall ratio was 9.7 to 1. And the number needed to biopsy was 13.4. And in a recent paper, that study from Pittsburgh, the dermatologist, number needed to biopsy was 25 to 1, and physician assistants 39 to 1. So, or number needed to biopsy, so 25 for the derms and 39 for the physician assistants, and we was at what did I say? 13.4. So we did well.
So I mean, I think for those one listening to this, those numbers that Dr. Polsky is throwing out there, that means like, let's say 1 to 25, meaning that for every 25 lesions that was biopsied that showed benign, and the physician found 1 melanoma. And for the PAs, that was number is 39, you said?
Yeah, 39, yeah.
That means the PA have to biopsy 39 to find 1 melanoma, right? So the goal is to decrease this benign to malignant ratio. That is,
right.
You want to get down as low as possible. That means so you don't over biopsy people, you don't turn people into this Swiss cheese, basically.
Right, and at the same time,
not miss a
melanoma, right? So we didn't miss melanoma, and to our knowledge, although we weren't really designed to check that because there's only things I recommended for removal, but we've done some other checking, and
but the key here is that you were actually able to find melanoma that's at the much thinner thickness compared to the average, right? So
exactly.
That itself shows that whatever you're doing, your skills, your expertise have allowed you to sort of detect melanoma at the earliest stage while minimizing the number of biopsies.
Right. And the take-home message wasn't Dr. Polsky's good at what he does. The take-home message was, this is a platform that Steve can do, as well or better than me. So it's really, the message was the platform is a good platform for dermatologists who are interested in this kind of thing, that they can do it. So
So let's shift gear a little bit. And so we talked a little bit about diagnosis. We talked about this stuff. You were involved with, I mean, you and I sort of got involved a little bit about 20 years ago with artificial intelligence detecting skin cancer with a Malafine device, everything.
Right.
But recently you were involved with this newer device that I think it's got FDA approved. It's NevaSense, right?
Right.
Can you talk to a little bit about what this technology is? And
So we weren't involved in the initial NevaSense stuff, but we've been working with the device as part of a clinical study, which I'll tell you about. So and I've got no financial conflicts of interest with NevaSense. I can tell you that they loaned us a device for our clinical study, but that I have not received any personal compensation. So NevaSense is a really interesting idea. I was really highly skeptical of it when it first came out, because basically it's a probe that you put on the skin, just kind of like my finger on your skin there, and it passes an electrical current through this electrode, which is really not much bigger than your fingertip. So from one side of the tip to the other it's passing this electrical current through the skin, and it measures the flow or the resistance through the skin, and it seems to be that it's different in melanoma versus benign skin lesions, melanocytic skin lesions. And they did a very nicely done prospective trial, and they showed that it has a very high sensitivity, meaning that when it's positive, it doesn't miss melanoma hardly at all. I think it was about 93% sensitive, and the specificity was something like 35% specific. So pretty good. And they compared it to the clinician on their own, and the numbers were better. The specificity for the clinicians, is much lower, as we were alluding to with the benign to malignant ratio. If you have about a 35% specificity, it's really like a 3 to 1, and roughly, and not hardly missing, melanoma. So, matter of fact, the sensitivity may have been a bit higher. I'm not sure, but it was definitely in the 90s, maybe mid to high 90s. So the caveat is the FDA approval is that it can only be used in a dermatologist's office. And the reason is that if you put that probe on something that's not a mole and not a melanoma, well, I should say basically not a mole, because a mole will give you generally a low score. It has a scale of 0 to 10, and moles will be basically 3 or less. But you could put it on a wart, okay, and it'll score like over 3. It'll score like in the melanoma range. But we know it's a wart, so of course we're not worried that it's melanoma. But the reason, there's other things besides warts that people have on their skin that are not so obvious. And if you put this on something that's not in the melanoma family, right? It's not a mole or a melanoma. It can give you a high score, and then you could start biopsying based on that, and you're going to do a lot of biopsies that you shouldn't be doing. And we encountered this in this clinical trial that we're doing, where we said purposefully, we're doing this telemedicine study on spot check, where people can come in. We advertise to the general public in a newspaper. If you have up to 3 spots on your skin, your concern could be skin cancer, come in and we'll do our what we call spot check, which is dermoscopy, teledermoscopy, kind of like MoleSafe, but just 3 spots. And then let's do a Neva sense to see if that can help us, even more. And what we learned is that most people come in with things that are not moles or melanomas. They're seborrheic
Like seborrheic
keratosis,
keratosis,
right? Yeah,
most
like warts,
common.
basically, pigmented warts. Yeah. So Neva sense, we didn't do a formal analysis, but it's like, well, it's probably not so useful in this setting, because it gave us a high number, and we didn't end up using the
So
information.
technically, this too, it's so you need multiple filters and screening. Right?
That's
The
exactly
first
right.
is you got the human being, the expert dermatologist who know that, okay, this is, I want to differentiate, to tell the difference between melanoma and an atypical nevi, not like basal cells, squamous
That's
cells,
right.
pigment decay, warts, all that stuff, right? And then
That's right.
once you pass through the first human filter, and then you put the probe on, and then you
Yeah, and
FDA
then it
will
can be
help you.
useful. Yeah, as a matter of fact, there was a really good study that we would like to replicate, which was in the Sydney Melanoma Group. Pascal led with Scott Menzies, where they used Nevasense on atypical moles that they normally would follow up 3 months later. So these are these kind of like
Yeah.
watch and wait kind of things, because we really don't think they're melanomas, so we're not going to rush to biopsy, but we're going to get a dermoscopy image 3 months after the first one and see if there's change. So they did Nevasense on all of those, and they found that if you raise the threshold for the Nevasense, you can safely manage these patients, and you could go to something like a 90% sensitivity to detect melanoma and something like a 70% specificity.
Wow.
So yeah, they
No,
missed
I
like
think
one.
that is a
Yeah,
really, really valuable thing, right? Because
yeah,
you can imagine, like sometimes you put, you tell the patient, we don't really know, we don't think so, but come back in 3 months. Most patients is like they have that sense of anxiety, right? It's
yes, that's
like
right.
3 months down hanging around, but now you have this probe and you can measure it, that really sort of can alleviate,
Yeah, exactly.
the
Because what they said was, okay, the doctor, the human said come back in 3 months, but if you put the probe on it and it scores 3 or below, they never found a melanoma. So they said, you know what, those people don't even have to come back in 3 months. Even though the doctor thought it looked suspicious, the Nevasense was able to tell them, no, it's okay, you don't have to come back. So that could be a real,
yeah.
again, relieve people's anxiety.
Or
And
even just biopsy at this moment if the Neva sense tells you
that's
much
right.
higher.
That was the other thing. If
Yeah.
it scored 7 and higher, they're like, don't come back in 3 months. Don't
Let's
move.
do it now. Yeah,
Let's do
yeah,
this now. Yeah,
yeah.
yeah,
No, I think that's a really good application. Okay, we talked a lot about the clinical setting, right?
yeah.
And we got to talk a little bit about your research because
Sure.
some of your work is really interesting. From your perspective, you sort of gone to all this kind of basic science, translational research. So you see what's around the corner, right? Can you sort of pull away the curtain and share with the audiences like what's around the corner? What are some of the exciting things that's going to happen?
Right, right. So, well, you mentioned our work, so I'll just very briefly mention that what our focus on is tumor biomarkers. So, basically, trying to identify patients who have a melanoma that's going to be more aggressive or less aggressive, and devise tools to help doctors manage those patients. And what we've been focused on mostly in recent years is circulating tumor DNA, which is DNA, and this is for basically patients with metastatic melanoma. The cancer cells die or they replicate so quickly that they have cell turnover, and they have small fragments of their DNA that has mutations in it, ends up in the bloodstream. And we're basically developing tests to monitor patients using that blood test to see, who's likely to do better or worse on their treatment. So and then hopefully we can get these tests into the clinic where doctors can actually use them, because right now there really are no blood tests for melanoma, in contrast to some other cancers where people follow the blood marker, for the cancer, and that helps them decide, what to do. For the metastatic melanoma patient, they go in for frequent CAT scans, and there's really no blood test. So we're hoping to develop a blood
And
test.
does this DNA marker that's circulating in your bloodstream apply to all type of metastatic melanoma, or is this a special variant or special, let's say BRAF mutation
Right,
positive, or is
right.
it doesn't really matter which BRAF status?
Right. So our approach has been find get a small piece of the tumor and look to see if that BRAF mutation is there, or another mutant is called NRAS, and then there's another gene called TERT, which is actually very frequently mutated in melanoma. So we have 7 different assays for mutations in these 3 genes, and our strategy has been choose one of those mutations, because BRAF and NRAS usually don't occur together, and if we can't find one or the other of those, we look for a TERT mutation, and then we have a test that we can use for that patient. It's almost like personalized medicine, in a sense that it's the test for the patient. And those 7 assays basically are found in a couple of studies that we've done, and just about 90% of melanoma patients will have one of those 7 mutations.
So,
So
just step back a little bit. I'm
yeah,
trying to think, how would you deploy this in the clinical setting? Do you actually have to analyze the tumor biopsy tissues to find out exactly like which one of the mutations
yeah,
it
yeah,
has, and then you just basically measure that specific. Let's say if you have BRAF,
exactly.
you only look for BRAF, it's
That's right.
NRAS, but why not just do all 7?
Well, our approach. So there are companies that do that sort of thing,
Yeah,
and they do. It gets a bit technical, but they basically use a sequencing methodology.
yeah.
We use something called droplet digital PCR, which is a different kind of approach that's more sensitive at the molecule level, if you will. That's a technology that we've been, working on, and we think it has advantages because it is more sensitive at the individual molecule level, and it's much less expensive than the sequencing-based assays. So that's why we prefer that. We think that in the long run, if these assays can perform well, that payers are going to be more interested in paying for a less expensive assay, and also something that can be used to monitor the patient. So you might get this, a broader sequencing approach very early on in the patient's disease course, but it might be too expensive to check every 3 months or something like that. Whereas our test, we think, can be done on a more frequent basis because the cost will be less.
Do you worry about, let's say, one clone of cells, one clone of melanoma, let's say carry the BRAF, right? And that clone is eradicated. And
Yeah,
but you have some other smaller clone like NRAS, right?
right.
Even though they don't come or
Well, you're hitting
together.
on a great topic, because that's another area of our interest, which is tumor heterogeneity.
Yeah,
And
exactly. That's the word.
yeah, so we and others have shown that this can happen. And one of the resistance mechanisms to BRAF targeted therapy is the emergence of
Yep.
NRAS mutant tumors. So it is something that we do think about. We haven't gotten there quite yet in terms of developing assays for those patients after the targeted therapy doesn't work. We do know that we still see patients, you know, BRAF mutant patients who the BRAF goes up after they've been treated with the BRAF targeted therapy. So the targeted therapy doesn't really eradicate all the clones of
For
the
sure,
BRAF
for
mutants.
sure.
Yeah.
I
So,
really
but it's
hope, I
yeah,
really hope this works, because now you can avoid potential need for putting patient into this PET scan, CAT scan, getting them dose and high dose of like radiation, right?
yeah, yeah. And then
I'm gonna,
also
okay,
so
okay.
the last thing,
No, I think we're
yeah.
running out of time, and
Ah,
we,
okay,
it
sure
seems
thing.
like this is all this kind of interview. We can sit here and talk about this all day.
Forever. Yeah,
Okay,
exactly.
I'm gonna give you the last word. What, you've seen so many patients, right? And you've seen the progression of the clinical development. What words of like inspiration, or hope, or wisdom that you want to leave
For
for
the
the viewers?
patients.
For the
For the
viewers who's
viewers.
watching this stuff.
Right. Yeah. Well, just a quick plug. You asked me about what's around the corner. So I would say immunotherapy is continuing to advance.
For sure. For sure.
There's very exciting developments in that space with treating patients with immunotherapy even before surgery for the metastatic disease, and developing some personalized vaccines. You know, this looks very exciting. I would say that for patients, the one thing I like to tell people is and it's going to sound technical, but is to understand the staging system. Now they don't have to understand the
Yeah.
staging system, but they need to understand if they have stage 1 melanoma, you know,
Yeah.
the chances are that they are going to be cured by their surgery. It's like 98% chance that they're cured by their surgery. So they shouldn't freak out, okay, when they have stage 1 melanoma that's properly evaluated, you know, by the pathologist and treated by the surgeon. It's easy to get, of course, really scared. I wouldn't want to have one myself, but just to have confidence that, you know, we've learned over decades that that when it's caught early, melanoma is a curable disease by simple surgery.
Well, David,
Yeah.
I can't thank you enough for taking the time. I know you're super busy, everything else, and thank you so much for joining us on the Beating Melanoma Project. And I'd love to have you back, and to hear more about some of the stuff you're doing. Hopefully, we can get an update. Maybe next time I talk to you,
Okay.
that you will give us more data. All right.
Been
Thanks
my
again.
pleasure.
Bye.
Bye.